My name is Dr. Sherif Negm. I'm a professor in the Department of Obstetrics and Gynecology, Cairo University, and today we will be talking about amenorrhea. There are two types of amenorrhea, primary amenorrhea and secondary amenorrhea. Primary amenorrhea, which is the non-occurrence of menarche by the age of 14 years with no sexual secondary sex characters, or a bit later, we can wait up to 16 years, provided that girls started to develop secondary sexual characters. So if she doesn't have a period by the age of 16 years, even if she does have secondary sex characters, this is also referred to as primary amenorrhea. Secondary amenorrhea, this occurs after regular cyclical bleeding. That means that the patient previously had normal menses and then suddenly she started not having her periods at all. This is known as secondary amenorrhea. What are the causes of amenorrhea? And they may be physiological, of course, before puberty and after menopause, this is normal. Also during pregnancy, there are no menstrual periods, and of course during lactation. All these are normal times for a female not to have her cycles. There are many pathological causes. Of course, the causes are different, whether the patient has primary or secondary amenorrhea, but we'll talk about them first in general. Outflow tract disorders, such as a perforate hymen, as you may imagine, this may result in primary amenorrhea rather than secondary amenorrhea, as do Mullerian anomalies, in which the patient does not have a uterus, and Turner syndrome. Ovarian disorders such as Turner syndrome, all these are causes of primary rather than secondary amenorrhea. Pituitary gland disorders such as pituitary adenomas may cause primary or secondary amenorrhea, depending on when they happen. Hypothalamic and CNS disorders such as rapid weight loss and excessive exercise, depending on when they happen, may result in primary or secondary amenorrhea, as do endocrine disorders such as hypothyroidism. First, we'll talk about the outflow tract disorders. These disorders describe cases in which there is obstruction of the menstrual flow at the level of the hymen or the vagina or the cervix. Such cases usually present, as we said before, primary amenorrhea, usually at a young age, with normal development of their secondary sexual characters. Why? Because the ovaries are normally functioning and the patient is producing a normal level of estrogen, so she has normal secondary sexual development, but with obstruction of the menstrual flow. Because menstruation occurs but is not revealed, as we just said, this type of primary amenorrhea is commonly known as false amenorrhea or cryptomenorrhea, because the patient is actually menstruating, but there is a mechanical obstruction to the outflow of the menstrual fluid. The most common type is the imperforate hymen. This is a congenital anomaly in which the hymenal orifice is absent. The condition may affect up to 0.1% of newly born females. Obviously, it may not be apparent at birth and may only present when the girl starts having pain at the time of menses with no revealing of the menstrual blood flow. This is the commonest cause of cryptomenorrhea. The pathogenesis, as we said, at puberty, menstruation will start, but the blood will accumulate behind the imperforate hymen, and this will lead to distension of the vagina, first leading to what is known as hematocolpos, and then as the obstruction remains undetected, the blood will also accumulate inside the uterus, resulting in hematometra, and then the blood will spread retrogradely into the tubes, resulting into hematosalpinx, and if the condition is unchecked further, it will also affect the pelvis, resulting in retrograde menstruation and may lead to endometriosis. The clinical presentation, the girl at the age of puberty, she will start having her cycles, but she will not have any bleeding. And as a result, she will have primary amenorrhea, but with normally secondary characters, secondary sex characters. Of course, she'll have lower abdominal pain, synchronous with the time of the menstrual blood flow, but the pain is usually more severe because of the distension of the vagina and later distension of the uterus. On examination, when we inspect the lower abdomen, they reveal a suprapubic bulge only if the hematocolpus is large enough to extend upwards into the suprapubic region. Inspection of the vulva and the vagina, the hymenal orifice is absent and If hematocolpus is large enough, the hymen itself will be bulging and the hymenal ring with a slight bluish color will be seen. PR examination will reveal a very sizable distension of the vagina, known as the hematocolpus, can be easily palpated by PR examination. The most easily available tool for confirming our diagnosis is to do a pelvic ultrasound, and this is considered to be the gold standard for diagnosis. Treatment, because it is a mechanical obstruction in the lower part of the genital tract, it is fairly simple, and this involves a surgical cruciate incision in order to relieve the obstruction. And you can see here from this schematic diagram, you can see the picture up here on the left. You can see this is the appearance of the labia, and this is the labia majora, and you can see the labia minora that are spread out, and you can see the distended bluish hymen. You can see from this sagittal view of the pelvis, you can see the spine at the back and the pubic symphysis here anteriorly. And you can see the distended uterine cavity and the distended cervix and the vagina with blood. And this is the appearance of the cruciate incision after the operation. It's a simple surgical procedure that results in relief of the obstruction. As you may imagine, one of the complications of this surgery is that this surgical incision, if it is not large enough, it may close later on, resulting in re-obstruction. So we have to be minded that when we do the incision, it has to be large enough to avoid re-occlusion. Transverse vaginal septum is similar to a hymen, perfect hymen, but the level of obstruction is higher, and this is the second most common cause of cryptomurria. It also presents similar to that of imperforate hymen with cryptomurria. The diagnosis also is similar, with hematocolpus diagnosed by ultrasound, while the hymen, if present, is apparently normal. So on inspection, the hymen will appear normal, and you may not see anything on pelvic examination, and we usually depend upon ultrasound or even MRI to confirm our diagnosis. The treatment is surgical excision of the transverse septum, but as you can imagine, because the transverse septum is higher up in the pelvis, its division is more surgically challenging, and if we're not careful, because in front of the transverse septum there is the bladder and behind it there is a rectum, so there is a greater risk of injury to these structures, so we have to be careful when dividing the septum that we not injure any nearby structures such as the bladder anteriorly or the rectum posteriorly. And you can see at the level of the obstruction, E here is the level of the hymen, and here you can see successively higher obstruction, D, C and B, successively higher levels of transverse vaginal septum. As you can imagine, the higher the level of obstruction, the more difficult is the surgical repair. Cervical atresia, this is an extremely rare form in which you have a normal functioning uterus but with an atretic cervix, and this will result in accumulation of blood only in the uterus with no hematocolpus, because there is no communication between the uterus and the vagina. Of course, blood will not accumulate in the vagina, it will only accumulate in the uterus and above in the tubes, resulting in hematosalpinx and maybe result earlier into endometriotic ovarian cysts. This is the most difficult type of atretic condition to be treated. You may attempt to form a communication or canalization between the body of the uterus and the vagina, but this is usually prone to atresia and closure, and many cases end up doing a hysterectomy in order to avoid the complications of retrograde menstrual flow, resulting in hematosalpinx and endometriosis. Next we'll talk about the uterine abnormalities, and these include usually complete or partial Mullerian agenesis, complete androgen insensitivity syndrome, and Asherman syndrome. The first one is the Mullerian agenesis. What this basically means is that the uterus has not formed either partially or completely. So that the patient has a normal female karyotype, 46XX, but there is absence of formation of both the uterus, cervix, and the upper vagina. One theory is this may be due to unwanted intrauterine exposure to anti-Mullerian hormone. As you know, anti-Mullerian hormone in the fetus is not produced by females. It is mainly produced from the testicles in order to induce atrophy of the Mullerian structures in the male. Sometimes it may be there is exposure of anti-Mullerian hormone in utero in female girls, resulting in failure of formation of the uterus, cervix, and the upper vagina. Its incidence is quite rare, 1 in 4,000 females, accounting for almost 20% of cases of primary amenorrhea. It's the second most common after Turner syndrome. Clinically, it usually presents with primary amenorrhea but with normal sexual development. Why? Because the girl has normal functioning ovaries and she'll have normal breast development, normal pubarchy, etc. The gonads, as we said, will develop normal from the genital ridge and are capable of producing normal amounts of estradiol due to the intact hypothalamic pituitary ovarian axis. On PV examination, this is usually not very helpful, but if you do it, you'll not be able to view any vagina. You'll only see a very small vaginal orifice, usually with a very blind-ended short vagina, absence of the cervix and the uterus. We usually depend on pelvic ultrasound or even MRI to confirm the diagnosis. Of course, karyotype is very important in order to exclude other conditions such as mixed or pugogonadal dysgenesis. Here we find a normal female karyotype 46XX, confirming the diagnosis that this is actually a case of Mullerian agenesis. Management, of course, there's no hope for fertility in these patients, and the only thing to do is to try and lengthen the vagina in order that the patient, if she wants to get married, she can have some sort of sexual activity, and this can be done either by progressive dilatation of the vagina with dilators, and if this is not successful, we can do some sort of surgical operation such as a McIndoe procedure, which lengthens artificially the length of the vagina. Another condition is known as complete androgen insensitivity syndrome, which is known as for testicular feminization. This is the old name. In this case, the individual has a male karyotype, so genetically it is a male individual, and it is usually an X-linked inherited recessive disorder, so it can be transmitted several times to the male offsprings. Androgen resistance here happens due to a defect in the peripheral androgen receptors, and they present by primary amenorrhea and with female external genitalia and a blind-ended vagina. As you can remember from embryology, the normal or the default embryological development of the internal and external genitalia is along the female line. So if the individual does not have a gonad at all, she will develop a uterus and she will develop female external genitalia. In case of androgen insensitivity syndrome, there is a normal functioning gonad that produces both testosterone, and it also produces Mullerian inhibiting substance. And the Mullerian inhibiting substance, as you know, will cause inhibition of the development of the Mullerian structures. So this individual will not have a uterus, but because the external genitalia is insensitive to the effect of androgens, she will or he will by default develop female external genitalia. Of course, these gonads, because they do not descend downwards into the labia or in unfused scrotum in this case, they are prone to develop gonadal tumors, and thus the management is usually by gonadectomy and creation of a new vagina, such as a McIndoe operation. And these individuals, although they are genetically males, they are reared as phenotypic females. Hormonal therapy, of course, is very important in these individuals in order to avoid the occurrence of osteoporosis, and they have to take estrogen preparations for life. Another condition, which is usually iatrogenic, is the Asherman syndrome, which is intrauterine synechia. Asherman syndrome described acquired intrauterine adhesions which prevent endometrial proliferation, leading to secondary amenorrhea. Etiology: this usually happens because of endometritis, and in many cases, or majority of cases, this is iatrogenic following a surgical procedure such as surgical evacuation for abortion, or after delivery puerperal sepsis, or intrauterine device obstruction, or very rarely due to pelvic tuberculosis. Clinical presentation: after normal menstrual cycle, the patient complains of secondary amenorrhea, or sometimes just hypomenorrhea, in which she has regular cycles at the expected time, but they're much lighter in the form of slight spotting at the expected time of her menses. Diagnosis can be done by hysterosalpingography, in which you'll find that the cavity is shriveled and very shrunken. Hysteroscopy is also very helpful, and 3D ultrasound can also aid in the diagnosis. Treatment is by hysteroscopic lysis of adhesions or through DNC-like procedure. Of course, this procedure is not very successful in the majority of cases, because once the cavity is destroyed by adhesions, in the majority of cases will not have normal regular cycles, and of course the chances of conception become markedly reduced unless the patient has very filmy intrauterine adhesions that can be cut by hysteroscopy. The chance of having a normal cavity restored once again are very minimal, even in the best of hands using very advanced hysteroscopic techniques. Secondly, we'll talk about ovarian disorders. The most common is the Turner syndrome, which is the gonadal dysgenesis. In Turner syndrome, a chromosomal defect occurs in which an X chromosome will be missing, so that the individual will have 45 chromosomes and a missing X chromosome, and the ovaries will be replaced by fibrous tissue, which are streak gonads. It is the commonest cause of primary amenorrhea, being responsible for 30% of cases. And they have a characteristic phenotypic appearance because of the missing X chromosomes. They have a short stature, and also they have an absence of development of the gonads. The gonads usually are streaked, and because they are streaked, they usually have failure of secondary sexual development, complete failure of secondary sexual development. The uterus is also very small and infantile, but on phenotypic examination of the external genitalia, as we said before, because the external genitalia do not require any hormonal influence to develop into female phenotype, they usually have female phenotype on external examination. Also, there are some phenotypic appearances such as low set hairline, small fingernails, widely spaced nipples, brown spots or nevi all over the skin, and of course, because they have rudimentary ovaries or streak gonads, they don't have any menstruation. What is the pathogenesis? Because of the absence of the Y chromosome, which allows for normal, as you know from embryology, the Y chromosome is important for two things: development of the gonad into a testicle, and the testicle, as you know, produces anti-Mullerian hormone, and it also produces testosterone. So if you don't have this Y chromosome, the internal development will be along female lines, so that the Mullerian duct will develop into a normal uterus, vagina, and fallopian tubes, and the external genitalia, because they, as we said, they do not require any hormonal influence, they will develop into external female genitalia. But because these gonads are streaked, they do not have any follicles inside them. So at puberty, the streak gonads would fail to produce enough estrogen, leading to hypergonadotropic hypogonadism, leading to primary amenorrhea. Treatment: of course, the first thing we have to consider is hormone replacement therapy in the form of cyclic estrogen and progesterone in order to induce regular cycles, and this is done in order to induce development of normal secondary sexual characters, and also to act as a prophylaxis against osteoporosis. In some cases, you have a mosaic karyotype in which you have 45XO and 46XX. Sometimes these patients have some follicles inside their gonads, and they have some years of menstruation, but they usually have premature ovarian failure, and very few of them have been able to achieve conception. Premature ovarian failure or insufficiency. This describes a condition in which there is early exhaustion of ovarian primordial follicles before the age of 40 years, leading to premature menopause. The etiology is either idiopathic, associated with autoimmune ovarian destruction, karyotypic abnormalities, such as a loss of a small portion of the X chromosome, viral infections such as mumps, or induced by radiation exposure or chemotherapy or surgical removal. The clinical presentation, patients usually have normal regular cycles, but they are usually cut short, resulting in premature menopause, resulting in secondary amenorrhea with very high levels of FSH and LH and very low levels of estradiol. And the treatment in these cases is to offer hormone replacement therapy, as we said before, in order to preserve the secondary sex characters and to avoid osteoporosis. Sometimes you have something known as the resistant ovary syndrome. This is secondary amenorrhea of high levels of FSH and LH, may occur when viable ovarian follicles fail to respond to pituitary gonadotropins due to a defect in either FSH and LH receptors. And in a few cases, the condition may be temporary, and in some cases, ovulation may resume. Another common condition, very common, and it usually results in secondary amenorrhea or irregular cycles, known as Polycystic ovary syndrome, describes a syndrome characterized by chronic anovulation, hyperandrogenism in association with multiple morphological and histological changes in the ovary. This is the commonest cause of secondary amenorrhea due to pathological and anovulation. Clinical presentation, there is usually secondary amenorrhea, although amenorrhea is not very common. Usually these patients complain of oligomenorrhea or irregular menses. Sometimes they have menstrual cycles once every 2 to 3 months. This is the most common presentation rather than secondary amenorrhea in association with one or more of either hirsutism, infertility, and obesity. Diagnosis, pelvic ultrasound. There's a characteristic picture with increased size and volume of the ovary, result with also dense stroma and peripherally arranged equal size small follicles, what is known as a necklace or string of pearls appearance. On hormonal evaluation, you'll find that the LH is disproportionately higher than the LH, resulting in an LH level that is more than 2 times higher than the FSH. Also, there is elevation of the total testosterone level, which also results in manifestations of hyperandrogenemia in the form of hirsutism and acne, and increased level of dihydroepiandrosterone sulfate. In some cases, however, they show also increased insulin resistance with hyperinsulinemia. And the treatment, of course, will be according to the patient's complaint. If she's complaining of irregular cycles, we give her, the most usual treatment is in the form of oral contraceptive pills to give her regular cycles. And when we choose oral contraceptive pills for the treatment of polycystic ovary, we try to use one with a progestational compound with the minimal androgenic effect in order to minimize the androgenic side effects in these patients. If they're complaining of hirsutism, we usually give them treatment for hirsutism, such as cyproterone acetate. And if she's complaining of infertility, we usually start her on ovulation-inducing blood testosterone clomiphene citrate as a first line of treatment. Number 4, we'll talk about the anterior pituitary gland disorders such as pituitary adenomas, empty cell syndrome, and pituitary insufficiency. Hypothalamic and CNS disorders, these very rarely you may have congenital GnRH deficiency, and in this condition the hypothalamus will not be producing GnRH, and so as a result the pituitary will not produce FSH and LH, and this will result in something known as hypogonadotropic hypogonadism. Sometimes you have psychiatric disorders which may lead to also associated deficiency in gonadotropic hormone production. Rapid weight loss and excessive exercise may also result in defects in the pulse frequency or amplitude of GnRH production, resulting in abnormal FSH and LH production. Iatrogenics, such as certain drugs, such as GnRH agonists, which sometimes are used to induce artificial menopause in patients with endometriosis, if we need to lower the level of estrogen in order to treat the endometriotic deposits in the pelvis. We also use the GnRH agonist as a precursor in controlled ovarian stimulation IVF cycles. Progestins for the treatment of irregular cycles, as we said previously, some of them have androgenic side effects and may induce amenorrhea. Combined estrogen-progesterone therapy, although this usually results in regular cycles if it is given cyclically. Androgenic drugs such as danazol, which are sometimes used in the treatment of endometriosis, may also induce amenorrhea. Antipsychotic and tricyclic antidepressants, which may be used in patients with psychiatric disorders, may also result in abnormalities in GnRH frequency and amplitude, resulting in amenorrhea. Hypothalamic tumors and infiltrated lesions, of course, anything that destroys the hypothalamus or the pituitary gland may lead to amenorrhea. Sometimes the patient have overt endocrine disorders just as hypothyroidism, in which there is very elevated thyrotropic releasing hormone, result in elevated levels of serum prolactin, and this results in hypothalamic hyperprolactinemia, and in turn results in amenorrhea. Cushing syndrome, increased adrenal activity, also leads to hyperandrogenic state, resulting in increased cortisol and increased production of androgen, resulting in amenorrhea. So how can we evaluate a case of primary amenorrhea? The first thing we have to do is to take a history and physical exam of the patient and perform a few basic investigations. First, we have to perform a pregnancy test, just to exclude the outside chance that the patient is pregnant, although this is a rare cause of primary amenorrhea. As we said before, we have to exclude endocrine disorders, so we have to do a TSH and a prolactin test. If the TSH is very elevated, then the most probable cause is hypothyroidism, and the patient can be treated with thyroid replacement. If she has an abnormally high level of prolactin, then we can do an MRI to exclude the presence of pituitary micro or macro adenoma. If all these are normal, then we have to examine, we go on the next step. The first thing to do is to see if the uterus is present or absent. If the uterus is present, then we do hormonal profile. If you have low FSH and LH level, then this is most probably functional amenorrhea, usually a cause of hypogonadotropic hypogonadism, and this may be constitutional, maybe due to excessive exercise, or maybe due to pituitary gonadotropic releasing tumors. If you have normal FSH and LH level, this may be due to outflow tract disorders, and this can be, of course, seen by normal examination or by ultrasound. If you have elevated FSH and LH level, then this means that despite that the hypothalamus and pituitary are functioning normally, the ovary is not responding, and here you have a case of primary ovarian insufficiency, and in this case we have to order a karyotype in order to determine whether the individual is a male or a female. If the individual has a female male karyotype, then this may be due to a case of androgen insensitivity or a pure gonadodysgenesis. If you have an XO, then this is most probably a Turner syndrome. Next, if the patient or individual does not have a uterus, then also we have to perform a karyotype and do a free and total testosterone level. If you have a normal karyotype, 40% 46XX, then this is most probably a Mullerian agenesis. If there is a Y chromosome, then this is an androgen insensitivity syndrome. And as you see, the main difference between androgen insensitivity syndrome and something such as a Swyer syndrome, in which you have gonadal dysgenesis, is the presence or absence of a uterus. In Swyer syndrome, you have a normal uterus because there is no anti-Mullerian hormone, so that the individual develops normal internal female genitalia. While in androgen insensitivity syndrome, the individual has a normal testicle, and this testicle produces anti-Mullerian hormone, resulting in atrophy of the Mullerian structure, so that the individual will not have a uterus developing. And but both will have amenorrhea, and both will have a Y chromosome. Secondary amenorrhea is a bit different. First, we have to exclude, as we said, all the previous disorders: pregnancy, abnormal hypothyroidism, or hyperprolactinemia. And if any of these conditions are present, then they are treated accordingly. If you have abnormally high TSH level, then order thyroid function and treat thyroid disease. If you have an abnormally elevated prolactin level, then you do an MRI to exclude macroadenomas. If these are normal, then you go on to the next step and do FSH and LH, and see, and the management will be according to the result. If you have elevated FSH and LH, then you have to repeat it after a month just to make absolutely certain. And if they are very, very high, then this is unfortunately premature ovarian failure in this individual, primary ovarian insufficiency, or natural menopause. You have to order a karyotype if this happens very early, if the patient is still in her 20s, on the outside chance that the patient has a form of Turner syndrome, as we said before, some cases of mosaic Turner may have a few years of normal menses, and then they have a premature menopause, so you have to exclude a mosaic Turner. If you have a classic Turner, usually they do not have secondary amenorrhea, they usually present with primary amenorrhea. If you have normal or low FSH and LH level, then you have to look at other possibilities. If does the patient or individual has evidence of disordered eating, excessive exercise, or poor nutritional status, then this is most likely functional amenorrhea, and consider dietary modification or modifying the exercise, reducing the amount of exercise, especially in competitive athletes. If there is evidence of high intracranial pressure, such as headache, vomiting, vision changes, then consider doing an MRI of that to exclude the presence of a neoplasm. If there is evidence of hyperandrogenism in the form of acne or hirsutism, then order serum testosterone, dihydroepiandrosterone sulfate, and 17-hydroxyprogesterone testing. If you have an elevated dihydroepiandrosterone sulfate, then you have to consider something in the adrenal glands. If you have such as adrenal problems, if you have an elevated 17-hydroxyprogesterone, then you could consider late onset congenital adrenal hyperplasia. If you have only elevated testosterone and the patient meets the criteria of polycystic ovary, then this can be the diagnosis, but you also do have to do an ultrasound of enlarged ovaries with the, as we said before, the necklace appearance. If the patient has a history of obstetric or gynecological procedure, consider induction of withdrawal bleeding or hysteroscopy to evaluate for Asherman syndrome. Thank you very much for listening.